Auscultation is the most important examination technique for assessing airflow through the tracheobronchial tree. Auscultation involves 1. Listening to the sounds generated by breathing, 2. Listening for any adventitious, added, sounds, and 3. If abnormalities are suspected, listening to the sounds of the patient's spoken or whispered voice as they are transmitted through the chest wall. Remember, before beginning auscultation, ask the patient to cough once or twice to clear mild atelectasis or airway mucus that can produce unimportant extra sounds. Listen to the breath sounds with the diaphragm of your stethoscope after instructing the patient to breathe deeply through an open mouth. Always place the stethoscope directly on the skin. Clothing alters the characteristics of the breath sounds and can introduce friction and added sounds. In this video, first we will discuss natural lung sounds. Remember, headphones are required. Vesicular sounds are soft and low pitch, which doesn't have gap between inspiratory phase and expiratory phase. Also, inspiratory phase is longer than expiratory phase. As shown here, vesicular sound is only heard on axillary line. If vesicular sound is heard in any other part of lung, it would consider as consolidation. Listen to this example. Bronchial sound. Bronchial sound is loud, high-pitched sound which has gap between inspiratory phase and expiratory phase. Bronchial sound should be auscultated over the manubrium, larger proximal airways. If bronchial sound is heard in any other region of lung, it would be considered as consolidation. Listen to this example. Bronchovesicular sounds. It's intermediate sound with intermediate pitch, also with inspiratory and expiratory sounds both equal in length without any gap. Bronchovesicular sound is auscultated often in the first and second anterior intercostal space and between the scapulae. Listen to this example. Adventitious lung sounds. Listen for any added, or adventitious, sounds that are superimposed on the usual breath sounds. Fine crackles are softer, higher pitched, and more frequent per breath than coarse crackles. They are heard from mid to late inspiration, especially in the dependent areas of the lung, and change according to body position. They have a shorter duration and higher frequency than coarse crackles. Fine crackles appear to be generated by the sudden inspiratory opening of small airways held closed by surface forces during the previous expiration. Examples include pulmonary fibrosis and interstitial lung diseases such as interstitial fibrosis and interstitial pneumonitis. Also, it is bit normal in older people. Listen to this example. Coarse crackles appear in early inspiration and last throughout expiration, have a popping sound, are heard over any lung region, and do not vary with body position. They have a longer duration and lower frequency than fine crackles, change or disappear with coughing, and are transmitted to the mouth. Coarse crackles appear to result from boluses of gas passing through airways as they open and close intermittently. Examples include COPD, asthma, bronchiectasis, pneumonia, and heart failure. The crackles of heart failure are usually best heard in the posterior inferior lung fields. Listen to this example. Wheezes. Wheezes are continuous musical sounds that occur during rapid airflow when bronchial airways are narrowed almost to the point of closure. Wheezes can be inspiratory, expiratory, or biphasic. They may be localized, due to a foreign body, mucus plug, or tumor, or it can be heard throughout the lung due to asthma, primary levels of CHF, pulmonary edema and primary levels of COPD. Recent studies suggest that as the airways become more narrowed, wheezes become less audible, culminating finally in the silent chest of severe asthma requiring immediate intervention. Bronchi are considered by some to be a variant of wheezes, arising from the same mechanism, but lower in pitch. Unlike wheezes, bronchi may disappear with coughing, so secretions may be involved. Listen to this example. Stridor is a continuous, high-frequency, high-pitched musical sound produced during airflow through a narrowing in the upper respiratory tract. Stridor is best heard over the neck during inspiration, but can be biphasic. Causes of the underlying airway obstruction include tracheal stenosis from intubation, airway edema after device removal, epiglottitis, foreign body, and anaphylaxis. Immediate intervention is warranted. Listen to this example. Pleural rub. A pleural rub is a discontinuous, low-frequency, grating sound that arises from inflammation and roughening of the visceral pleura as it slides against the parietal pleura. This non-musical sound is biphasic, heard during inspiration and expiration, and often best heard in the axilla and base of the lungs. Listen to this example. Mediastinal crunch. A mediastinal crunch is a series of precordial crackles synchronous with the heartbeat, not with respiration. Best heard in the left lateral position. It arises from air entry into the mediastinum causing mediastinal emphysema, pneumomediastinum. It usually produces severe central chest pain and may be spontaneous. It has been reported in cases of tracheobronchial injury, blunt trauma, pulmonary disease, use of recreational drugs, childbirth, and rapid ascent from scuba diving. Listen to this example. Transmitted vocal sounds. If you hear abnormally located bronchovesicular or bronchial breath sounds, assess transmitted voice sounds. Egophony. Ask the patient to say E. You will normally hear a muffled long E sound. If E sounds like A and has a nasal bleeding quality, an E to A change, or egophony, is present. Bronchophony. Ask the patient to say 99. Normally the sounds transmitted through the chest wall are muffled and indistinct. Louder voice sounds are called bronchophony. Hint: localized bronchophony and egophony are seen in lobar consolidation from pneumonia. Whispered bacteriloquy. Ask the patient to whisper 99 or 123. The whispered voice is normally heard faintly and indistinctly, if at all. Louder, clearer whispered sounds are called whispered bacteriloquy.